Welcome to the Deep Dive. We're here to take those dense, complex sources. Today, it's the bedrock text, Harrison's Principles of Internal Medicine, and really pull out the core insights you need.
Yeah, and today's focus is, well, maybe the toughest part of medicine, making those critical calls when you just don't have all the answers.
Exactly. It's that fundamental tension, isn't it? Osler called medicine a science of uncertainty, an art of probability. You can know all the facts, but that's not enough.
Not for real mastery, no. It's about mastering the choice itself under pressure with incomplete information.
So that's our target today. If uncertainty is like baked into the system, how is modern medicine trying to get a handle on it? We're diving into the section in Harrison's covering formal decision support tools, evidence-based medicine, basically how we try to make decision-making less uncertain.
Right. The mission here is charting that shift, moving, beyond just relying on gut feeling system one or even just slow, deliberate calculation system two. We're looking at how we integrate computational power, how we systematize evidence.
To boost accuracy,
Yeah.
reduce errors.
Precisely. Boost accuracy, get more consistent, and yeah, fundamentally cut down on human error where we can. So we'll unpack artificial intelligence in medicine, statistical risk models, EBM evidence-based medicine, and the reality of clinical guidelines.
Okay, let's jump right in then. Decision support systems and artificial intelligence, or AI, computers in medicine. Sometimes feels like they've promised more than they've delivered over the years. What's the actual role now?
Yeah, at the basic level, yeah, they're information gateways, huge amounts of data at your fingertips. But sorting it, that's the hard part. The real decision support comes when the system starts offering, actual guidance.
Like predictions.
Exactly. Tools that can predict patient outcomes with some accuracy or even simulate the best decision pathway using algorithms. That's where it gets interesting.
And Harrison's breaks down AI, right? It's not just one big thing. What are the main types we're seeing in the clinic?
Yeah, you can think of it in roughly three categories. First two are sort of the foundations, neural networks and machine learning.
Machine learning is the pattern recognition one.
That's the one. Especially deep learning, which is a subtype. It's incredibly good at finding subtle patterns in massive data sets. Think radiology images, skin lesion photos.
Spotting things a human might miss.
Potentially, yeah. Or at least flagging areas for the clinician to look closer. They're often used as diagnostic aids, assistants, if you will.
Okay, and the third type, the one making all the noise right now, generative AI. Things like GPT-4.
Exactly. Large language models, they can create new content, summarizing complex stuff, drafting clinical notes, maybe helping with admin tasks. The potential for efficiency gains, huge.
But I sense a but coming.
There's a big but. Harrison's really emphasizes this, using these big language models for direct clinical decision-making, like telling the doctor the diagnosis or the exact treatment that's still very, very preliminary.
So the hype is maybe ahead of the reality for actual treatment decisions.
You could say that. The enthusiasm often runs way ahead of the proven, validated utility in those high-stakes clinical moments.
And that gap, that leads to risks. The text mentions automation bias first. What's that look like in practice?
It's a real psychological trap. Early studies show clinicians can sometimes just accept what the AI says, even if it seems off or contradicts what they know about the patient.
They just trust the machine.
It seems easier sometimes. The algorithm gives an answer, it feels authoritative, it takes effort, system two effort to step back and critically question it. So yeah, there's a bias towards just accepting the automated output.
That sounds particularly dangerous when paired with the next issue, model confabulation, which is basically the AI making stuff up.
Pretty much. Sometimes called hallucinations. The AI generates information that's plausible sounding but factually wrong or just fabricated, and it delivers it with complete confidence.
Oh, wow. So a confident lie plus a bias to believe it.
It's a recipe for potential harm, serious harm.
Which brings us to the absolute necessity, the mandate, before these tools are widely used.
Validation. Rigorous, careful, comprehensive, and independent validation. It's non-negotiable. We have to treat these algorithms like we treat a new drug. Meaning it has to be tested thoroughly in a different group of patients than the one it was trained on. If it only works on its training data, it's useless, potentially dangerous in the real world. You need proof it's generalizable and reliable.
It's interesting, though. While that complex AI is facing these hurdles, some of the simpler systems are actually doing quite well.
Absolutely. Often the simplest tools are the most effective right now. Things like reminders built into the electronic health record, the
Like
EHR.
drug dosing reminders.
Exactly. Adjusting doses for kidney function, flagging drug interactions, things that need standardization.
Yeah.
These systems enforce guideline adherence where, human memory or attention were slipped. They've shown real benefit.
And the simplest tool of all, the checklist.
Never underestimate the checklist. Seems basic, right? But in high-pressure places like operating rooms, ICUs, they've had a massive impact, just making sure key steps happen every time. Reduces errors, improves workflow. Simple, but powerful.
Okay, so shifting gears a bit, from AI predicting things to decision analysis. Harrison's calls this a normative prescriptive approach. Sounds different from AI.
It is different. If AI often describes how doctors do think or predicts what will happen, decision analysis focuses on how decisions should be made to get the best outcome under uncertainty. It's prescriptive, it sets a standard.
It gives you a formal way to choose.
Yes, a framework for making the optimal choice when outcomes are uncertain. And it often forces you to put numbers on really complex trade-offs.
Trade-offs that aren't easy to quantify, like quality versus length of life.
Precisely. Or patient preferences versus limited resources, or the chance of a cure versus the certainty of side effects. Decision analysis makes you assign values or utilities to these outcomes so you can mathematically compare different strategies. It's really useful for policy-level questions where you can't just run a trial.
Like the big example in the text, the CIS-NET analysis on breast cancer screening from 2016. You can't easily randomize women to different screening schedules for decades, right?
Exactly. It's impractical and ethically difficult. So the CIS-NET model stepped in. It used decision analysis to compare different strategies, starting age, how often to screen.
And the key finding.
The key finding, which really influenced guidelines, was that for average risk women aged 50 to 74, screening every 2 years, biennial screening seemed to be the most efficient approach.
Let's dig into why the model suggested that. It shows the trade-offs so clearly.
Okay, so compare biennial screening from 50 to 74 versus doing nothing. The model showed it avoided about 7 breast cancer deaths for every 1,000 women screened. Pretty good.
But what about a more intensive strategy? Say screening every year, starting earlier at 40, going up to 74.
That strategy avoided only 3 more deaths per 1,000 women. So a marginal gain in lives saved.
3 more lives. But at what cost? This is where the model really highlights the downside.
The cost was huge. That annual from 40 strategy needed roughly 20,000 extra mammograms for those same 1,000 women over their lifetime. And crucially, it resulted in nearly 2,000 more false positive results.
Almost 2,000 women told they might have cancer needing more tests, biopsies, anxiety.
Exactly. 1,988 more false positives, to be precise. So the model showed that tiny extra benefit, those 3 lives, came with this massive burden of extra testing, false alarms, anxiety, and resource use. It wasn't saying screening is bad, but it helped pinpoint the optimal balance point for population health policy.
That's a perfect lead-in to risk prediction models, the foundation for figuring out individual risk. We know simple judgments aren't enough.
Not in complex medicine. Bayes' rule is foundational, sure, but it's usually about one probability. Real patients have multiple things going on. You need multivariable models, things like logistic regression that can weigh several factors at once.
Factors that might overlap or interact.
Right. The model assigns statistical weights to each piece of information, history, symptoms, labs. It does a calculation a clinician just can't do reliably in their head.
Harrison's uses the Wells criteria for pulmonary embolism, PE, is the classic example. Everyone learns this one. How does it work conceptually?
The Wells score, and others like it, are pretty straightforward in structure. They list specific clinical features and assign points. So signs of a deep vein thrombosis, a DVT, that's 3 points, heart rate over 100, 1.5 points, history of a previous PE or DVT, another 1.5 points.
You just add up the points based on the patient in front of you.
Yep, add them up. The total score then slots the patient into a risk category. Less than 2.0 might be low probability, over 6.0 is high probability.
And that score then guides the next steps.
Exactly. It's powerful because it moves beyond just a gut feeling. It gives an objective risk estimate that helps decide, okay, does this low-risk patient just need a D-dimer test, or does this high-risk patient need to go straight to a CT scan? It standardizes the workup.
And these models, Wells or CHA2DS2-VSC for atrial fibrillation stroke risk, they're getting built right into EHRs now.
More and more, yes. Which is great for accessibility, acting as a safety net.
Back to the big caveat.
Back to the big caveat. Independent validation, always. An unvalidated risk score is like an unproven drug. You have to be skeptical. Does it actually work in your patient population or just the one it was developed in? It needs that rigorous testing.
Okay, before we leave this calculation section, we need to touch on the visual tools that help understand test accuracy. The receiver operating characteristic curve, the ROC curve. Can you unpack what that graph actually shows?
Sure. The ROC curve is basically a picture of a trade-off. Anytime you have a test with a continuous result, like a blood sugar level, you have to pick a cutoff point to call it positive or negative. The ROC curve plots the sensitivity, the true positive rate, how well it finds the disease when it's there on the vertical axis against the false positive rate, that's 1 minus specificity, how often it wrongly flags someone healthy on the horizontal axis.
So if I set my cutoff really, really high to be super sure someone's positive, what happens on the curve?
If you set a very high, strict cutoff, you minimize false positives. So your specificity goes up, and the false positive rate on the x-axis goes down, moving you left on the graph.
But I'll miss people who have the disease but aren't that high.
Exactly. Your sensitivity will drop. You'll miss true positives, so the point on the curve moves down. Conversely, if you lower the cutoff to catch everyone, highest sensitivity, you'll inevitably get more false positives, lower specificity. The curve shows you can't max out both at the same time. You always trade one for the other.
And the overall quality of the test is?
Measured by the area under the curve, the AUC. A perfect test, discriminating perfectly, would have an AUC of 1.0. The curve goes straight up and straight across. A useless test, like flipping a coin, has an AUC of 0.5, following the diagonal line. Better tests have curves closer to that top left corner.
And choosing where on that curve to operate, which cutoff to use, that's a clinical judgment call.
It absolutely is. It depends on the consequences. Is it worse to miss a diagnosis? False negative, or worse, to overtreat or do unnecessary biopsies, false positive. For something like cancer screening, you usually prioritize sensitivity. You accept more false positives to avoid missing cancers.
We also have those handy mnemonics for interpreting tests based on their characteristics.
Yeah, Sunnout and SMPTN, very useful. If a test has very high sensitivity, SN, a negative end result makes the disease unlikely, helping to rule it out. No.
Another one.
If a test has very high specificity, SP, a positive P result makes the disease much more likely, helping to rule it in SMPTN. They're quick mental shortcuts for the test's power in confirming or excluding.
Okay, moving from describing tests to actually updating our beliefs based on results. This brings us to the core math, Bayes' rule. Harrison positions this as the antidote to cognitive biases, like sticking to your first impression.
It is. Bayes' theorem mathematically describes how to update your probability estimate after getting new information, like a test result. It calculates the post-test probability, how likely the disease is after the test.
And it combines what?
3 things. Your starting point, the pre-test probability, how likely you thought the disease was before the test, based on symptoms, prevalence, etc. And then the test's characteristics, its sensitivity and specificity.
We don't usually calculate the full formula by hand, though.
Rarely. We typically use a related concept, the likelihood ratio, or LR. It simplifies the calculation, especially using a tool called a nomogram. The LR tells you how much a specific test result shifts the odds of disease.
Okay, let's break down the LRs. There's a positive LR and a negative LR. What's the LR positive tell us?
The LR positive is the ratio of the true positive rate, sensitivity, to the false positive rate, 1 specificity. Essentially, it asks, how much more likely is this positive result in someone with the disease compared to someone without it?
So a big LR positive is good.
Yes. An LR positive greater than 10 is generally considered strong evidence to increase your suspicion of the disease. A value between 5 and 10 is moderate, 2 to 5 is weak. Below 2, it barely shifts the odds.
And the LR negative?
That's the ratio of the false negative rate, 1 sensitivity, to the true negative rate, specificity. It tells you how much a negative result decreases the odds of disease. Here, you want a very low number.
Lower is better for ruling out.
Much better. An LR negative below 0.1 is considered strong evidence to decrease suspicion. Between 0.1 and 0.2 is moderate, 0.2 to 0.5 is weak. Above 0.5, a negative test doesn't really help you rule out much at all.
Harrison's uses a coronary artery disease, or CAD, example to show this in action, comparing a standard stress test to a more advanced SPECT scan.
Right. So a standard exercise treadmill test, it's okay, but not great. It might have an LR positive of maybe 2.4. The SPECSA scan, a nuclear imaging test, is more accurate. Its LR positive might be around 9.0.
Okay, now take a patient who's in that gray area intermediate risk. Say their pretest probability of having CAD is 50-50.
Right in the middle, maximum uncertainty. If that patient has a positive standard treadmill test, LR positive 2.4, their post-test probability moves from 50% up to about 71%. Better, but maybe not definitive.
But if they have a positive SPEC scan, LR positive 9.0.
That same 50% pretest probability jumps way up to about 90%. See the difference? The test with the stronger LR gives you much more diagnostic certainty, especially when you start in that uncertain middle zone.
But the text makes another crucial point. The pretest probability really matters. Testing isn't always useful.
That's a key clinical insight. If your patient starts with a very high probability of disease, say 90% based on classic symptoms, even a positive test with a high LR might only nudge that probability up slightly, maybe to 98%. It probably won't change your decision to treat or investigate further.
And the same at the low end.
Exactly. If the pretest probability is very low, say 5%, even a positive result from a moderately good test might only raise the post-test probability to, say, 20 or 30%. That might still be too low to justify invasive procedures or treatments. The takeaway is test utility depends heavily on where you start. Don't just order tests without thinking about the baseline risk.
So before we shift to the bigger frameworks like EBM, we have to acknowledge the consequence when this process goes wrong. Diagnostic error. Harrison's paints a pretty concerning picture.
It does. The statistics are quite sobering. Estimates suggest nearly everyone will experience at least one significant diagnostic error in their lifetime. And these errors cause real harm, delays in treatment, wrong treatments, unnecessary costs, morbidity, even mortality.
But the thinking has shifted, right? It's not just about blaming the individual doctor anymore.
Thankfully, yes. The modern view, strongly emphasized now, is that diagnostic errors are often symptoms of system of care deficiencies, meaning things like communication breakdowns between teams, faulty information transfer during handoffs, EHRs that aren't well designed for decision support, or even just workflow pressures that encourage cognitive shortcuts, like jumping to conclusions too quickly, what's called premature closure.
So the solutions need to be systemic too.
That's the focus, improving the system. Things like embedding decision support tools, using checklists for high-risk situations, designing better EHR interfaces, improving team communication protocols. Attacking the system vulnerabilities is seen as more effective than just telling doctors to be more careful.
Okay, that's a good transition into the frameworks designed to improve the system of knowledge itself. Let's talk evidence-based medicine, or EBM. How is it defined now?
EBM is presented as sort of the modern evolution of clinical judgment. It's about integrating the best available scientific evidence with clinical expertise and, importantly, patient values and preferences. The emphasis is really on the process of how we acquire and apply knowledge.
And there's a specific process, right? Harrison's lays out 4 steps that define EBM.
Yes, these 4 steps are key. 1, you have to clearly formulate the clinical question you're trying to answer. Make it specific.
Cool.
2, you systematically search the medical literature to find relevant research data that addresses your question. 3, this is the critical appraisal step. You evaluate the evidence you found for its validity, is it good quality research, and its applicability, does it actually relate to your patient?
And finally,
4, you integrate that appraised evidence with your own clinical expertise and, crucially, with the patient's unique circumstances, values, and preferences. This leads to shared decision-making.
that sounds incredibly thorough and also really time-consuming for a busy clinician.
Oh, absolutely. Performing a full, rigorous EBM appraisal for every patient question is completely impractical in routine practice. It would take hours.
So how do clinicians actually do EBM day to day?
They rely heavily on shortcuts, primarily high-level summaries of evidence like systematic reviews and meta-analyses. Resources like the Cochrane database specialize in producing these. The idea is that experts have already done steps 2 and 3 for you.
But you mentioned earlier, these summaries are only as good as the studies they include.
That's the massive caveat. A systematic review can't create good evidence out of bad studies. If the underlying research is flawed, small sample sizes, poor methodology, bias in the review will inherit those flaws. Harrison's uses that great phrase, quote, cannot make silk purses out of sow's ears. You still need to critically assess the review itself.
The text uses the COVID-19 pandemic as a stark lesson here.
Yeah, it was a perfect storm, in a way. The early pandemic literature was just flooded with weak evidence case reports, small observational series, often with conflicting results. It caused immense confusion.
And the lesson from that?
It powerfully reinforced why we need rigorous evidence. Small observational studies might generate ideas in a crisis, but they are absolutely not a reliable basis for setting standards of care. They're just too prone to bias and chance findings.
So what are the pillars of reliable evidence then? What should we be looking for?
According to Harrison's and general consensus, there are two main workhorses: randomized clinical trials, RCTs, and large, well-conducted observational registries or databases.
Let's compare them. RCTs are still the gold standard for intervention questions.
For internal validity, yes, randomization is the best tool we have to minimize bias, especially selection bias. It makes it much more likely that any difference seen between groups is actually due to the intervention, not some underlying difference between the patients.
High internal validity, but the downside.
Often external validity or generalizability. To get that clean result, RCTs often have really strict entry criteria. The patients enrolled might be younger, healthier, have fewer other diseases than the typical patients you see in clinic. So you're left wondering, do these results really apply to my complex patient?
And observational studies from big registries, they flip that.
Pretty much. They often include a much broader slice of the real-world patient population, so their findings might be more immediately generalizable, higher external validity. Plus, you can study things you could never randomize, like the effects of smoking or different environmental exposures.
But the internal validity is the worry.
Big worry. Treatment selection bias is the huge one. Why did certain patients in the registry get treatment A and others get treatment B? Was it because they were sicker, younger, had better insurance? These confounding factors are incredibly hard to fully account for, even with fancy statistics, so you can't be as confident about cause and effect.
Okay, so we have this evidence, ideally from good RCTs or registries. How do we synthesize it quantitatively? Meta-analysis.
Right. Meta-analysis takes it a step further than a qualitative systematic review. It statistically combines the results from multiple similar studies, ideally using the individual patient data from each trial, if possible.
Why is that pooling powerful?
It increases the statistical power. You might be able to detect a smaller, but still clinically important treatment effect that wasn't obvious in any single smaller trial. But again, the same garbage in, garbage out principle applies. Pooling flawed studies just gives you a more precise estimate of a flawed answer.
Now, a really critical point in EBM that Harrison's emphasizes.
Yeah.
Moving beyond relative risk numbers to absolute risk. Why is that distinction so vital?
Because relative risk can be misleading, or at least incomplete. A drug might cut the relative risk of something by 50%, which sounds amazing.
Yeah.
But if the starting risk was tiny, say 2 in 1,000, cutting it by 50% means the risk is now 1 in 1,000. The absolute difference is minuscule.
So the absolute risk reduction, the ARR, is what really matters to the patient.
It's much more meaningful for individual decisions. The ARR is the simple difference in event rates between the treated and untreated groups. And from that, we get the most practical metric, the number needed to treat, or NNT.
NNT, that's 1 divided by the ARR?
Exactly. NNT equals 1 ARR. It tells you how many patients you need to treat with a therapy for a specific period to prevent one additional bad outcome or achieve one additional good outcome.
And the crucial insight here is that the NNT is not fixed for a given drug or treatment.
Absolutely not. This is maybe one of the most important concepts. The NNT depends entirely on the baseline risk of the patient or population you're treating.
Let's use the example from the text to make this concrete. A therapy gives a 33% relative reduction in mortality.
Sounds good.
Sounds great. Now apply it to a high-risk group. Let's say their baseline mortality risk without treatment is 12%. The therapy reduces this by 33%, so the new risk is 8%.
Okay, so the absolute risk reduction, ARR, is 12% minus 8%, which is 4%, or 0.04. Right, so the NNT is 1 divided by 0.04, which equals 25. You need to treat 25 high-risk patients to prevent 1 death. That feels pretty efficient, clinically worthwhile.
Okay, now take that same drug, same 33% relative benefit, but use it in a low-risk group. Say their baseline mortality is only 6%.
The therapy reduces that 6% risk by 33% down to 4%. So the ARR is now 6% minus 4%, which is only 2%, or 0.02.
And the NNT becomes 1 divided by 0.02, which is 50.
Suddenly, you have to treat 50 low-risk patients to prevent that same single death. You're exposing twice as many people to the potential costs, side effects, and burden of treatment for the same amount of absolute benefit.
That difference, NNT25 versus NNT50, is huge for clinical decisions, resource allocation, everything.
It's fundamental. It's the mathematical basis for targeting treatments to those most likely to benefit. It shows why a one-size-fits-all approach based only on relative risk is often wrong. You have to consider the baseline risk.
Okay, finally, all this evidence, modeling, and risk assessment is supposed to feed into clinical practice guidelines, or CPGs. How does Harrison's define their role?
They use the Institute of Medicine definition. Systematically develop statements to assist practitioner and patient decisions. The goal is to improve quality, reduce variability, and promote best practices based on the evidence.
And they're developed by expert panels, reviewing evidence, grading it.
Yeah, there's usually a formal process. A panel reviews the literature systematically, assigns grades to the quality of the evidence for different questions, weighs the benefits versus harms, and then makes recommendations.
Sounds good. But then comes the kicker. The research cited, particularly from cardiology guidelines, shows a surprising weakness.
It's a very sobering finding. When researchers actually looked at major cardiovascular guidelines, they found that less than 15% of the recommendations were based on high-quality, grade A evidence, meaning multiple, large, consistent RCTs.
Wait, less than 15%? So what's the basis for the other 85% plus of recommendations that doctors follow?
Mostly lower levels of evidence, smaller trials, observational studies, and, or very often, expert consensus or opinion. Basically, in many areas, the high-quality trial evidence simply doesn't exist to definitively answer the clinical question.
So most guidelines are actually a blend of limited hard evidence and collective expert judgment.
That's the reality. It doesn't mean guidelines are useless. Expert consensus from experienced clinicians is valuable when definitive data is lacking. But it does mean we should view them as guides, not infallible rules etched in stone. They represent the best synthesis available, but often that synthesis relies heavily on judgment calls where the evidence is thin or absent.
That really changes how you think about them. They're assistants, not commands.
Exactly. Assistance providing a reasonable default pathway, but always requiring the clinician to ask, does this recommendation, based perhaps on limited evidence or consensus, truly fit the specific patient in front of me? #tag/4. Summary and final thought. All right, so wrapping up this deep dive into formalizing decisions, the big takeaway is that clinical mastery today isn't just about knowledge or intuition. It requires really getting to grips with these formal methods and tools to navigate that inherent uncertainty.
Okay, let's bullet point the key insights. 1. AI, especially generative AI, looks promising for efficiency, like writing notes. But for actual diagnosis or treatment advice, huge caution needed. Independent validation is everything to avoid harms like automation bias.
Right. 2, simple rules aren't enough for complex patients. We need those sophisticated statistical prediction models, think Wells criteria, to properly weigh multiple risk factors at once. The human brain just isn't built for that kind of multivariable calculation reliably.
3. Test interpretation isn't just about the test. The ROC curve shows the trade-off between sensitivity and specificity. Choosing a cutoff is a clinical judgment based on harms. And using likelihood ratios with the patient's pretest probability is how you actually update your diagnostic certainty.
4, when you're looking at treatment evidence from EBM, forget just the relative risk. Focus on the absolute risk reduction and the NNT, the number needed to treat. And remember that NNT changes drastically based on the patient's starting risk. That's critical for personalization.
And 5, those clinical practice guidelines we rely on. They're essential, but understand their foundation. Often, recommendations are based more on expert consensus than top-tier trial evidence. So treat them as valuable guides, but apply critical thinking to the individual patient.
These formal tools are essential for managing uncertainty in a structured way.
Here's the final thought we want to leave you with. Even when you have the best evidence, the most accurate prediction model, the clearest guideline, all of that is typically based on the average patient in a study. The person in front of you is unique. So the question remains, how do you ensure your own clinical reasoning, your judgment, constantly interacts with these tools? How do you know when to trust the algorithm and when, based on your understanding of this patient, you need to thoughtfully, rationally override it?
Yeah.
Because at the end of the day, that continuous refinement of your own critical thinking applied to the individual, that still feels like the ultimate foundation of truly good medicine.